Vibrant and funny panel behind me here, and oddly enough, it's called the Chief Medical Information Officer Panel, but they're actually quite a funny group. So they're
We've been told that before.
They're actually one of the funniest panels I have. But what they are supposed to talk about is lead an informative discussion on technology and how it can be used to cut costs and how it plays a role in population health management today and in the future, and focus on wearables. And they'll also share some of their thoughts and insights on what connected health means today from their individual perspectives, and then what it could look like in the next 3 to 5 years. And so with that, I'm going to turn it over to our facilitator for this panel, Shadab Kanwal, who's sitting right here, and he is the Executive Director, Research and Quality at Kaiser Permanente. Thanks.
Thank you, Jody. So, let's start with the funny panel. The fun part of it is, if you're in medicine, you have to enjoy the funny part. And the funny part is that if you are amongst your colleague, you always have fun. I am the oddball out here, right?
Yes.
So I don't have MD behind me or in front of me. I think it's behind.
It's more to your side.
All right, beside me. So I am always beside the MDs, kind of helping translate some of the language in the technology world. My role at Kaiser Permanente is I support the corporate functions of research, community benefit, health policy, international health, and the second part of my portfolio supports hospitals quality and care delivery excellence. Both of them are led by two senior, one executive vice president and chief medical officer, and a senior vice president who are part of the national executive team. Kaiser Permanente, I think most of you are already familiar with, so I don't think I need any introduction about Kaiser Permanente, or is there anyone who does not know about Kaiser Permanente? Howard has retired from Kaiser, so I'm going to give him the benefit of doubt on that. But it's a learning organization. Everybody learns new things about Kaiser Permanente. And what I'll take, the way I had a conversation with the panel via email was, why don't we have a little bit of introduction about ourselves so that you folks, if you have not read the brochure, know who you are listening to. This is a notable panel. They are the leaders of innovation and information and informatics in this Bay Area, and their outreach is beyond the Bay Area, and it influences the whole country. So I'm honored to introduce Howard. Why don't we start from your side?
Howard Landa. I am the Chief Medical Information Officer for Alameda Health System. AHS is the safety net organization for Alameda County, based predominantly in Oakland and surrounding cities. Been in informatics for almost 20 some odd years. And outside of my AHS position, I'm also the Vice Chair of the Association of Medical Directors of Information Systems. And I spent 15 years working for Kaiser, and after 15 years I retired I left Kaiser last December, and I was still learning about the way Kaiser worked, and I'm still not sure I understand it.
It's the one Kaiser now.
One Kaiser Plaza.
Right.
Once in a lifetime, you have to work for Kaiser. Let's put it that way. Rajiv, you also did the same?
Yeah, I worked 2 years at Kaiser. I did. Rajiv Pramanik, I'm the Chief Medical Informatics Officer at Contra Costa Health Services, which is the safety net in the next county over in Contra Costa. We're a predominantly large ambulatory system with a small hospital, and I've been in informatics probably after undergrad when I did an engineering degree and then went to medical school and went back and forth, and now I'm here.
Jennifer Tong. I'm the CMIO of Santa Clara Valley Medical Center, and we are also safety net hospital and ambulatory care setting. We have a large hospital, 574 beds, which is almost always at full capacity, and we pride ourselves on never turning anyone away, regardless of their ability to pay or regardless of how impacted we are. One of my favorite titles that someone has referred to me as is the medical records lady. I like to think of myself as being a little bit more than the medical records lady, and I came into technology somewhat later in life, helped lead the Epic implementation of our hospital 2 years ago, and then became the CMIO after that.
Wonderful.
Thank you. My name is Chris Longhurst. I'm the CMIO at Lucille Packard Children's Hospital and Stanford Children's Health. I have not worked for Kaiser. I also have VP responsibility for our analytics data warehouse team as well as our clinical informatics team at the Children's Hospital. And I'm the program director for the first National Clinical Informatics Fellowship, which is across Stanford Medicine. And it's a real pleasure and privilege to be here today. Thank you.
Chris, the pleasure is all mine, and I'm going to blame Justin on that. Justin is a physician also, and right in the middle of it, who basically got us together. So pleasure is all mine. The conversation that we are going to have today is, and you are an enlightened crowd, so I'm going to keep it open in that way so that it's a participatory conversation. And what I wanted to have a dialogue with my esteemed panel is to understand what keeps them up at night. That's to start with. And just to trigger off the conversation to see, what are the things that they are dealing right now, so that so their ideas will enable you to understand what are the most burning questions that they are dealing with. So how about Jennifer? We start with you on that.
Yeah.
Thanks. Well, security keeps me up at night, and protecting our health information is clearly one of the priorities of my job, making sure that we don't have a security breach of protected health information. At the same time, on the other side of that coin, making sure that we adequately share our health information with other providers. And at some point during the panel, we'll probably talk about the extent to which we have enabled sharing among other between Bay Area healthcare institutions. The other thing right now, keeping me up at night, literally, is our provider efficiency. Our providers have had such a steep learning curve over the last 2 years with transitioning from paper to a fully integrated electronic medical record, and we do feel like it's impacted some of our productivity and therefore our access to care. So we're really working hard on trying to make our providers as proficient as possible with the system, at the same time still trying to introduce new technical tools for them to challenge, to balance those two.
Awesome. Rajiv?
Well, this morning I got woken up because 80 of our users got deactivated by some kind of process where a report writer reset their security logins. But so I mean, there's both operational issues like that can wake you up at night, which you have no control over, because what can I do with that? Nothing. And then there's kind of trying to build tools to help clinicians, point-of-care tools, because there's a lot of talk about analytics and decision systems, but it doesn't work if it's not in the right workflow in the right place. So thinking about how we can make that more efficient, as we've given the clinicians a lot more information, but we haven't done it in a better way. So now they're just, they have 40 different charts all at one place, and they don't have any time to look at them.
How about I flip this way, and how about I give you the last word on that?
Okay. We have a slightly more interesting. Sorry. What? Go ahead. Go.
No.
I missed the. I never did understand what you said. We have a slightly more interesting problem. Being a safety net, we're definitely on the short side of the money stick. We implemented a software in EHR a couple of years ago that has actually been sold from one vendor to another. And the software that we're on for 3 of our 5 hospitals is actually, while it's going to be maintained for maybe 10 years, it's probably not going to be developed to the degree that we would like it to be. So we're looking at what we can do. So after literally 2 years on a system, we're now looking at replacing it with another entirely different system and bringing all 5 hospitals onto the same system and hopefully rolling out the ambulatory product for whatever vendor we decide throughout. So 3 or 4 years into an EHR journey, we're now going to shift gears, change directions, and do it again. and try to find the money to do that and do it as efficiently and cheaply as we can. The only upside is we've learned a tremendous amount, and we're going to take those learnings and try to apply them to do it better. But it is just still a huge challenge.
Thank you. So all those things keep me up at night too. And to talk about something unique, I'll build actually on what Howard said, which is although I'm at an honorary safety net hospital where we don't turn away any children who don't have the ability to pay, and we're extraordinarily solvent from a financial perspective, we still worry a lot about budget, particularly in the Stanford environment where we're challenged to innovate constantly. We have faculty members with grants looking to innovate, and yet the IT department as a percentage of our operating has continued to rise over the last 7 to 9 years as we implemented clinical technology. Just as a context for those that aren't highly familiar with healthcare, the airline industry spends somewhere from 10 to 12% of their operating revenue on automation in their IT departments. The banking industry spends around 15%. In healthcare, traditionally, we spent 2 to 3%, and that was to run financial and billing systems. As we've put in electronic health records and automated clinical workflows, many places are now spending 4, 5, 6, 7, 8%. And yet, as we all feel pressure from accountable care and healthcare reform, those are very, very difficult margins to run from a healthcare perspective. And so supporting all the innovation and forward-looking things that we want to do and we'll be talking about on the panel today in light of the constant budget pressures, I think is an important thing to be aware of.
Great. Thank you, Howard. Well, when we were outside, you were trying to, I'm taking a clue from the word innovation from Chris, and you were trying to define innovation for us. What do you think is innovation, within the healthcare space? How do you define that for us?
So it's interesting. When you look at healthcare, you expect to see something. You look in the news and you see, a new MRI scanner, a new procedure, new medications being developed. But when you start looking at healthcare information technology, the innovation is a little more basic. We're looking at supporting workflows. We're looking at making things more efficient, looking at making things safer. One of the biggest things we keep struggling with is how do we make this process safer and improve the quality of care and not really being able to define it. So at least in my world, big innovation is not something that we're going to do. We're not going to develop an EHR. We're not going to develop a whole new way of caring for patients. But it is kind of nibbling around the edges and trying to make the process better, trying to make it easier for clinicians to take care of patients and try to improve the care we deliver. I think one of the fun things about my world, I was a direct caregiver for 20 some odd years and just a few months ago stopped providing care directly. But there's a very nice compromise, a very nice differentiation between caring for one patient in a setting and then turning around and trying to provide tools for all of the physicians, nurses, and other caregivers to provide for all the patients in aggregate. So little things you do can create a real dramatic effect as it ripples through the organization. So I think the innovation is much smaller things that are more impactful versus change the world kind of things.
Rajiv, your thoughts?
Yeah, I completely agree. It's what Rome wasn't built in a day type thing. It's iterative and not like a waterfall type innovation. For example, today, when we first went live with our EHR 3 years ago, we thought we would have an easy refill process. You send the medication over, they send you back an electronic refill, and you sign it. Well, we found out about 2/3 of our, they were still coming back as faxes. So over a course of a year, we're up to 80% are coming in electronically, but it took working with more than 100 pharmacies, some bigger groups, and we're never going to get to 100%. 80% is actually a high benchmark, but it's iterative, slow, continual, put your head down and kind of keep walking, taking a step at a time.
Jen?
So I tend to be pretty simplistic, and I would define innovation as anything that's new for you that's of benefit. And Rajiv actually gives me a hard time because he'll say, Santa Clara is not really doing population health. And I'll say, for us, compared to what we were doing 2 years ago, we are doing some innovative population health things. It's not what you would really hope for in the long run, but I can tell you all of our panel PCP patients who have diabetes, and I can tell you what their last A1C was, and I can tell you when their last visit was and when their next visit coming up is. And so for us, that's been a very innovative transformation over the last 2 years, even though some sites wouldn't consider that necessarily innovative on a global scale. As they mentioned, it's a concrete example of the iterations of innovation.
So Chris, innovation, like Jen said, it's an introduction of a new idea, a new thought, a new product, a new way of doing it. And Howard said they are doing some process innovation. So what dimensions of innovation you have applied, since Stanford is a very innovative organization? What dimensions have you employed in terms of promoting, progressing, and propagating innovation at Lucille Packard?
Great question. Thanks. First of all, Rajiv, you got to stop giving Jen a hard time. That's just mean.
Yeah, I know. I got to apologize for that.
My turn?
I would build on what some of the panelists said. So first of all, a lot of people see health IT as predominantly technology, and we see it as just the opposite, right? Most of these interventions are people first, process second, technology is a distant third, and sometimes the least important piece of it. So I will give some examples, maybe to answer your question, of both some small innovations as well as some larger innovations, but I think you'll recognize that really it's more about the people and the process than it is the technology. So building on our previous comments about budget and costs, our CFO said, if you ever try to justify the return on investment of electronic health record, you'll fail. And I think that's true. I think this is the new cost of doing business, is these expensive systems and the capital it takes to implement them. That being said, there's all sorts of opportunities to find fiscal ROI when you have them in place. One of the best ones we had was around red blood cell transfusions. It turns out every hospital in the US pays the Red Cross per bag of blood transfused. And so any less blood used or reduction of overutilization is a direct cost savings to the hospitals. So recognizing that we had opportunity for improvement, we introduced an alert in our electronic health record a few years back. We hypothesized it would have a 10% reduction on overutilization of blood products. And what we found 12 months later was a 50% reduction in our medical surgical units. And that equated not only to $250,000 saved on an annual basis, but 500 less patients unnecessarily exposed to blood products. So that was an example of an innovation that hadn't been done elsewhere. And once we had shown the benefit, we actually founded a quality improvement collaborative. We now have 82 hospitals participating and have turned this role on at over a dozen other institutions. So if you want to learn more about that, I encourage you to visit crit.stanford.edu. That's a small example. On the other side, there were some larger sort of technology-enabled innovation efforts. One example of that was that we were approached recently by Apple and our EHR vendor about piloting HealthKit. And we've got a pilot off the ground now live with real children with type 1 diabetes who are now being monitored at home because their continuous glucose monitor data from a Dexcom CGM is flowing into our electronic health record and enabling that kind of population health management that Dr. Tong was explaining. So that wasn't easy to implement, but the bigger challenge is now who's going to watch that data, and how are you going to change your care delivery models to support the fact that you can now see this glucose data in between visits. So that's one example of a larger innovation. Another couple that we're looking at, for example, is innovation around telehealth. We're actually building out a mission control nerve center so that when we open our new expansion in 2017, we'll be monitoring all of our inpatients in a centralized station to improve patient safety, quality, and the healthcare experience for our patients and families. And then finally, I'd give an example of what is referred to today as big data. Tomorrow, I'm sure we'll have a different nom du jour. But we recognized that when the Joint Commission issued their Sentinel alert around alarm fatigue, that we had a lot of opportunity to reduce unnecessary bedside alarms. To do that in the pediatric setting, where these vital signs are age stratified, we actually went back to our data warehouse, pulled out 50,000 vital sign points over the last 12 months, and developed new curves for heart rate and respiratory rate in our hospitalized population of children. We've now implemented those new curves as vital sign limits, and one of our fellows in clinical informatics will be publishing a paper soon showing it's reduced our alarms by 30% in the hospital. So those are some examples of different types of innovation, and they've all been supported and aligned in different ways with the enterprise.
That is fantastic. You employed resource reward, your relationship, tools, knowledge, all of those in a combination. And when they collectively come together, that's where your cost drivers basically are another factor that kind of brings it down. Any thoughts of process innovation that you folks have done in your areas? Maybe we'll start with Rajiv on this one.
So we're a public hospital, so we have a lot of what's called DSRIP. And there's been a delivery system reform incentive payment. So the feds basically gave an amount of money to make sure that we have money available to invest in technologies, people, man-force, and resources to improve our safety scores and our outcomes. And we use that money to address things like sepsis, hospital-acquired infections, and put up dashboards. And we found just sharing transparency of data and developing dashboards have really changed the attitudes of our providers and clinicians in general. An example of that was if you don't close a record, you can't bill that record. So if the physician doesn't close that visit out, physicians for us are employed, so that visit isn't a direct revenue to them. But just sharing the data of how many encounters are open have changed that by 50%. So that accounts receivable part, that innovation, there's real ROI for us. I mean, Chris, you mentioned that how much the profit margins in most hospitals are less than 2%. Right, so if you're going to spend 9 to 10% on IT, which I don't think we do, but we wish we did, that's coming out of nowhere, right? You have to cut other costs. So the investments you make have to be very thoughtful.
Jen, any thoughts or any ideas to share?
So we've done a lot of work on our patient flow through the hospital. Being a very impacted system, it's common for us to have 100 patients waiting in the emergency room waiting room and an ER almost completely full of patients waiting to get upstairs to be admitted. So we've used our EMR to track data on patient flow points and provide real-time feedback to individual providers as well as specialty groups with defined targets in terms of, when the ER says this patient needs to be admitted, we need you to write that admission order within an hour. And yesterday, your team averaged 2.5 hours. And so what can you do for your next cycle when your team is on call to get that down to an hour? Likewise, we've really worked on our discharge process, tracking data on what time of day are physicians discharging patients from the hospital, how long does it take the nurse to actually get the patient out the door once the physician's written a discharge order, providing that data to individual units to try to make process improvements, and then all the way through to the bed cleaning process, providing, engaging our environmental services, showing them their data, how long it takes them to get a bed cleaned and turned over for the next patient. So that's been one of our biggest short-term successes.
Well, that's really amazing because, most of the time, innovation in the tools and technology industry is termed as creating a product, but creating a process that improvises the organization and creates that competitive advantage is the one that you guys have been able to do that. Howard, I'm interested to know, like when we are talking about, like a business model innovation, is that where Alameda is? Because I think there is not an easy competition out there. How have you guys transformed or created a business model innovation? Can you share something about that?
I go back to my Kaiser experience, and even before Kaiser, I was working at Loma Linda in Southern California. And back in the 90s, we started capitating patients. And we really found that when you capitate those patients and look at value instead of volume, you wind up reducing your costs and increasing the quality of the care you deliver if you do it correctly. Now, for those of you who are around for the meltdown of the 90s of managed care, a lot of it was because people were just trying to basically deprive care until someone decided that, you know, they just would change their insurance and go somewhere else. And when I joined Kaiser, a lot of it was because of what I learned about capitation. In our world, it's a little bit different. We are what I call pseudo-capitated, in that only about half of our revenue comes from actual patient care, and the rest comes from block grants and other things like the delivery system reform payments, in order to provide for patients who don't have insurance or are underinsured, illegal aliens, those who are, you know, kind of fall through the cracks. So when we look at how we're going to provide care, one of the big questions is not how are we going to drive income, because we don't have a lot of potential to do that, but it is how do we reduce costs? And how do we look for things like patient engagement, getting patients engaged with their care to reduce costs, getting them engaged with other social support areas. So, you know, we're looking more for how do we reach patients in ways besides the standard appointment. So putting together panel support groups, panel support teams to bring patients into a different setting, you know, group visits or reaching out to patients individually, sending people to homes or to areas where we have a number of patients and trying to intervene before they wind up coming to the emergency room. So a lot of things we do are technology enabled by providing information where someone is, providing remote access, but the real innovation happens with people, and it happens at the point of care. One of my favorite stories is actually back from when I was with Kaiser in Hawaii. We were working on improving our mammography screening rates, and we put alert in the system. We enabled people to order mammograms for who weren't physicians. So if people could request their own mammogram, the medical assistants and nurses could order it. And it really didn't drive numbers as high as we were hoping. And when we really started looking at it and you know, going back to the lean, ask why 5 times, you know, when we finally asked why things weren't getting done, we realized that one of the big problems was the results. So when a mammography result comes back, it goes to the physician who ordered it, or if they're a nurse or a medical assistant ordered it, came back to them. And a lot of people really weren't comfortable with dealing with the results. So there was a kind of a reluctance to place the order, because if you were not comfortable with knowing what the right thing to do, you really didn't want to get involved with it. So despite everything we did from technology, we weren't driving the benefit. But as soon as we put a small team together that would intercept those results, interact with the patients, get them the care they needed, figure out what needed to be done or not needed to be done, and provide a very rapid resolution to positives, to negatives, to intermediates, all of a sudden that fear of ordering the test went away, and we were able to drive our mammography rates to one of the top in the country. So it was technology enabled, but again, it comes to people, process, and really identifying an outcome that everybody can relate to.
I think innovation is about outcome. More specifically, it needs to address a business problem. And then if you are creatively thinking about within the norms of your organization, you don't radically have to change it. But a transformation does help in that way, to position you to be competitive. And in this day and age where we are moving from an industrial age to an information age, where all of you folks are bombarded with so much of the data, and that helps you in your decision making. How do you see, that care coordination processes, working between multiple data points and multiple data, points of information coming together? Do you see it's working, or what does our information technology industry needs to do? Chris, I'll start with you.
Great question.
Thank you.
I would reflect on some comments that were made earlier, which was our physicians in seeing patients used to be sort of isolated in a void of information, and now they're drowning in data without any real information. So as an example, you'll see a lot in the lay press about interoperability and accusations of vendors that are blocking interoperability, et cetera. Our experience in Northern California has actually been substantially different. We have found that at our organization in the last 12 months, we've exchanged 1.2 million documents on over 200,000 patients with 46 US states and 130 different organizations. So that's pretty mind-blowing statistics. But what that means to the doctor who's actually seeing that patient is that that chart might be actively electronically linked to 2 or 3 or 4 other organizations in the Bay Area or elsewhere. And now the 15-minute clinic visit that I already didn't have time for is more challenging because I've got access to a lot of information I'd like to look at but just don't have the ability to do. So that implies that we have real challenges to improve care coordination around things like data visualization and ensuring that the right information is available at the right time for these physicians who are already burdened with a loss of productivity because their workflow has changed.
And since we see this all moving towards a patient-centered and a physician, coordinated environment, Rajiv, how do you relate with that experience that Chris is going through?
I mean, before I was in the ER, if you knew it was volume 20, that means you could ignore volumes 1 through 19, right? Now you can't, so you're searching. I mean, so presenting of data and data visualization for the clinicians is very important. You can't have a cluttered view. It has to be 1 or 2 clicks away. So getting a lot of user interface design and people to help with that, working with your vendors for that is very important. I know out of Stanford, I don't know if you were involved, but they put out that data visualization of how Santa Clara, Stanford, all the EPIC organizations at least were sharing data. It was pretty amazing. So that interoperability is good. Now we just got to make it simpler and easier to see because the decisions are happening rapidly. The patients need to be involved. So we're working on engaging patients. It's hard in a safety net population to engage all of our patients. But as you make it easier, we kicked off a Spanish web portal where we're doing proxy, we're doing live translation, we're working with other institutions in California to have a healthcare interpreters network. So, I mean, those are little steps, but overall, it's really getting populations that are interested in their health outcome, but now are able to do it easier, and that's important, is to get both the patients and the clinicians to do their work easier.
So your approach is that you're taking a patient-centered approach where you are engaging the patient both culturally and digitally, and that's your integrated approach. Jennifer, how are you treating that kind of environment?
We're recognizing the need to grow new skills within our organization and potentially even some new roles within our organization related to 2 of the things that were just mentioned. First, more data analysts, not just analysts, but actually data scientists. Our CEO expressed to me last week his frustration saying, why don't we have any data on this issue? And I said, I can give you thousands of pages of data, but that's not actually what you want. You want a meaningful, actionable display of information, and it actually takes a surprising amount of time to get from those thousands of pages of data to something that is digestible, meaningful, and actionable. And we're struggling with developing people within our organization who not only have the skill set but have the time to commit to that. And then second, I think as we have more direct-to-consumer products, apps on cell phones, and patients come in asking about those things or bringing in pages of data or emailing pages of data to their physicians, we're actually going to need people who help manage that because there's really not time during the provider visit to delve into that and for the provider to really understand, what is this app? Is it effective? Is it valid? What do I do with all the data this patient's bringing me from this new thing that they have found on their own? So we're actually going to need people who understand new things that are on the market and help negotiate that for our providers.
So patient engagement means that, the patient is fully, the patient will see you now, docs, actually. I was with Eric Topol, last week, and he basically put out a cartoon where the patient basically is having the doctor, see the doctor, or your cell phone is going to be listed as your next, provider in that way. There's a lot of, lot of change in this environment that is happening. We have the mobile technology that is so much progressed, and a lot of the development of from a platform perspective is happening in there. We have a lot of sensor technology that has generated, and it's basically getting developed on the mobile space. Do you guys think that this is too much flood of data, and does that really make any meaningful information that can become actionable knowledge? And do you think, first of all, that's the first question, and if you can take the supplementary question also, and Howard, I'll start with you. Do you think this is a use case for a big data environment?
I'll take that. We'll come back to the big data question, because I think that's a whole different world. But I think that the amount of data that is available and theoretically is useful to clinicians is there's just so much noise that you can't get to the signal. So a patient who comes in with an Excel spreadsheet of all of their blood sugars for the last 6 months,
yes,
it's not really useful. And here's my blood sugars, here's my Fitbit steps, here's my sleep patterns, and how am I doing? And the average physician looks at all that and pushes it aside and says, so how you been doing for the last couple of days? Because we can't deal with it. And what is lacking, I think, to a large portion, is some kind of a middleware that puts it in perspective. So you can look at, like I said, blood sugars is a good example. You can do a median, you can do a high-low, but if you don't know what is going on when those readings are taken, then you're really working in a vacuum. So, for example, if you see really high blood sugars and really high steps, well, what does that mean? Well, the patient was at a wedding and ate a lot of cake, and their blood sugar was high, but they're really doing fine. And then a couple weeks later, you see, a low number of steps and a low blood sugar followed by a high blood sugar. Well, they got the flu, they were in bed, they weren't eating well, and then as they got better, they were making up their calories. So I think putting things in perspective and finding some way to integrate what is going on with the patient socially with medical data and really patient subjective data is where we need to get to if we're going to bring all of the wearable data and the patient enterable data into a perspective that we can actually use it. And until we get to that point, all we do is get inundated with noise, and I think we really set ourselves up for making bad decisions because you look at a series of numbers and you try to act on them because the patient is asking you to. And
right.
We wind up, kind of leaving the profession and the art of medicine, which was a real conversation and understanding of what was going on with the patient by looking at all of the structured data. And I think it's something we have to be very careful of.
So the art of medicine is really, growing. 20 plus years ago, I did a graduate thesis on telemedicine. I see it in reality happening, which is now termed as connected health also. So there's a different terminology that every time gets connoted. What do you see, Chris? Where is it going? I mean, like I can have a visit in Singapore with a multi-specialty physician in $20, where do you think it's going?
That's a great question, and we have unique perspective on it as an institution of pediatric subspecialists, whose care really can't be obtained many other institutions. That being said, I'm glad that the conversation about connected health started with the art of medicine. At Stanford, we have the famous author Abraham Verghese, who published Cutting for Stone, and he's been a real, I don't want to say anti-EMR advocate, but a cautionary signpost reminding people that the art of medicine includes the human touch and that we need to make sure that the patient doesn't become the eye patient. You walk around the hospital or the clinic and you see the physicians huddled over the electronic health record, entering that data, and the patients, sitting alone in their beds. So is there opportunity from big data and wearables? Unquestionably. Have we tapped it yet? I don't think so. There's very little published outcomes on the opportunity for you to use this for real impactful change. And even the big companies like Fitbit find that it's not as sticky as they thought. People will adopt it for 6 or 12 months and then they move on. And yet, whether you're visiting a patient from Singapore or as our pediatric urologist Bill Kennedy does, he sees patients while he's in China who are back here in the States. the important thing is that he already has relationships and connections with those patients. So he does pre-op visits, he does post-op visits, but he's not doing the pediatric urologic procedures by a robot. He's touching them in person and meeting their families in the waiting room. And so balancing the use of technology to enable new care delivery models with that human touch is really our challenge. And actually, I would point to your organization, Kaiser, as being a leader in this. 75% of Kaiser members are KP.org enrollees, and Sutter Health has actually done a tremendous job on this as well. They're also about 75%. That's industry leading. That means 75% of your patients can book their appointments online, securely message their clinicians, and look up their own test results and radiology results and things like that. And that's where we're going to need to go if A, the patient's going to be at the center, and B, we're going to reduce costs in a way that enables these activated patients.
Jennifer, do you have any comments?
Sure. I have a bit of a unique perspective on telemedicine. I happen to be married to the medical director for a telemedicine startup company, so I live, eat, and breathe this day in and day out, right out of the living room of my house. And I think it's phenomenal to think about the impact it can have on people's access to care. You know, the ability of people to not have to take a day off work to see a physician remotely. For people in our community who taking a day off work is a very significant impact to their daily life. It really has the potential to improve patients' ability to access care, have them not wait until it's too late and end up hospitalized. And for those who live in more remote areas, has great potential.
You know what? I do want to have an opportunity for you guys to ask a question or two. You know, if there is anything that in this conversation that appeals to you or you feel intrigued by, please by all means, you know, put your hand up and introduce yourself, and we'll definitely provide an opportunity to contribute.
Well, I'll start because I would say I'm sort of a micro VC because on a weekly basis I'm asked by a faculty member or CEO to meet with a startup company. And 9 times out of 10 what I find is that it's a startup company founded by an engineer who believes that the problems in healthcare are engineering problems and that engineering solutions will solve those problems. And so that often then requires a lot of education about all the non-market driven economy of healthcare, the regulatory environment, and the people and process issues. So the biggest advice that I have for startup companies like that is partner with somebody inside the health system and identify a real problem that you're going to solve. Because starting with the solution and the technology is back-asswards and ends up very frustrating to everybody involved. Starting with a problem that may or may not have a technology solution is a helpful way to start and often makes it easier to get in the door of health systems who have these thin margins and low budgets as well.
I think one other point, and I think Chris started going down this road about making sure that whatever you're doing fits in a clinical workflow if it needs a clinical workflow. Yeah. But even more important, can we provide tools to people to help take care of themselves? I mean, the physician is the highest paid provider in the healthcare system. After a dozen years of training, there are a lot of things we don't need to take care of. And how can we get everyone working at the top of their ability, and even down to the patient and family? And if they've got tools that they understand when they need a physician, when they need a health coach, when they need a minute clinic, wherever their needs are, if we can better get them to a part of an organization or a non-medical organization that can help them, that's going to really impact the system positively, because you need the physicians doing the stuff that physicians need to do, and so much of what we do is not really value add.
I think that's why our institution's starting to look at social determinants of care, and I'm sure everybody else is here. I mean, if a homeless patient, which we have a flag for, is coming in, there's only so much you can do that you think as a physician, okay, take your diabetes meds, take your this, why aren't you filling your meds? Well, they can't get to the pharmacy or no one pays for their prescription. I mean, there's a lot of layers of care that have bad clinical outcomes that aren't affected by clinical decisions. So from an institutional or community perspective, and I understand a lot of you are outside of healthcare delivery systems, those are the areas working with the community-based organizations and things that will really, hopefully, in the long run, help determine better outcomes than just fine-tuning the physician, nurse, or take this med and change it to half a dose. All of that stuff is very little, but costs a lot.
I volunteered in a medical clinic overseas for a while, and what I realized was that I was bringing medicine that helped temporarily, but what they really needed were civil engineers to, dig clean water sources and permanently solve the problem. What you described, Justin, is something very real we feel every day, but I don't think it's a technology problem. I think it's a policy problem, and it's driven by the regulatory requirements and compliance people and legal people and billing rules. It's not driven by the technology. As proof of that, I submit to you that our clinical informatics fellows are doing international rotations. And one of them just got back from Melbourne, Australia, where their children's hospital is implementing the same electronic health record that we have. But they have no rules around physician documentation, no rules around billing because the federal government pays for the hospital stay. And so every other day they document a few sentences in the electronic health record. Now, is that the best care? I don't know. I think an argument can be made there's probably a happy medium, but it shows it really isn't the technology that's driving this. It's the policies that we ourselves have subjected the culture to. And so when I have physicians frustrated with burnout and these same issues, moving that button here and reducing clicks might help, but it's not really the problem. The problem is the policies and the legislation.
Yeah, I have to agree. Through the meaningful use and other regulations, we have slammed EHRs in. I mean, many of us have been doing this for a couple of decades, and begging people to adopt order entry, decision support, electronic documentation for years, and we just made inches and inches forward, and all of a sudden 2008, 9 came around, 10 came around, and all of a sudden you go from a couple % of systems that have an EHR to 30, 50, 70% implementation, and you can't move that quickly without causing a lot of untoward consequences. And one of the biggest, and it drops on the physicians, and if there's anybody more burned out than the docs, it's the nurses. So it falls on the clinicians who are carbon-based to fix the silicon-based problems. And they do, and they're going to work their collective butts off to make sure that patients are safe and that we're taking care of stuff. But the net result of that is a lot of frustration with the technology. And I think we need to get the technology away from the interaction and get people back in, at least to some degree. And I'm hopeful that if you start looking at the meaningful use stage 2 regulations that are hopefully being softened and the stage 3 that are not quite as onerous as we thought they might be, we may be finally getting to the point where we can start investing in how do we make the tools better, how do we make them smarter, how do we make them easier to use? And I think technology can help there. So, but first we need to get the government and the lawyers out of the way.
So I'll take this.
I want to be a little contrarian, though, just to argue against. I think there's things like Stanford's doing with open charts where technology is trying to remove itself, right? Get the patient closer to the clinicians where they're able to document and see their documentation and say what matters to them and initiate that visit where the technology becomes more hidden and not in your face. Go to the screen. I mean, you have kids painting pictures of their doctor's visit, and the doctor's in front of a screen, and they're sitting there by themselves. We want to get away. So I think technology can help by trying to disappear more.
I mean, it's a great point, and I think it goes back, we started talking about the art of medicine, and it's understanding what that patient needs, and it's not always the antibiotic. And, sometimes you just need to listen, communicate, and interact. And the cultural differences do make it difficult. When you start looking at patient portals and other patient engagement tools, they're all in English. Maybe they're in Spanish. We have translators for over 100 different languages, and we actually have a cart that goes into the exam rooms that has a translator on a screen. So we have someone who speaks Korean, who speaks Vietnamese, who speaks Russian, interacting with that patient. And the facial features, the ability to see someone dramatically improves that interaction, but also doubles the length of time. So how do we get someone maybe that isn't the physician in working and getting information and doing those cultural things and alerting the providers, getting information in the record to help us figure out the best things to do, we're just scraping the surface on that. And but I think it is a whole huge area. Rajiv talked about, if they don't have a home, all the things that we do don't work. Well, even if they have a home, if at the end of the day you haven't addressed the way they need to take care of themselves, then everything you recommended just goes out the window.
Thank you very much, Howard. I think we had one more question, and that's probably the last one. I'm sorry we won't be able to do that one, but we'll take this first question on the beginning.
And we can stay around.
And we can stay around here. You can definitely come approach us. I can see
preferably with a beer in hand.
I can comment on that a little bit. So, we've implemented direct provider messaging, so patients can now directly email their provider, and it's a new opportunity to hear the patient's voice that we didn't have in the past. So, has really increased our communication between patients and providers outside of that single office visit, which might only be 20 minutes once a year. So, I think that for us has improved the ability of patients to feel they have an opportunity to reach their provider and have their voice heard. And we were worried about the impact it would have on our providers and the volume of messages they might get. So far, our experience has been that patients have used it rather wisely, and it has not been a tremendous detriment to our providers adding time to their schedule.
I think one other thing that is becoming a fairly common thing in the Oregon area, it's really being pushed, is a concept called open notes, where your entire narrative note is available to the patient, not just your diagnosis and your medications, but that entire prose that your physician created that talks about you, about how they heard what you said, what they're recommending, why they're recommending it, and what your next steps are, the education piece of it. Getting all of that allows the patient to understand what the provider is at least hearing, which really opens up the conversation to say, you wrote, this is what you said, that's not what I told you. And I think that opens up a whole nother area of communication that is at least a response to that. But I think, as we talked before, that the interpretation, video interpretation, translators, and understanding the different cultural pieces of it is something that we're just really beginning to do.
Yeah, I would agree with that. We have both direct provider messaging for patients as well as pilots and open notes. And open notes is a great example, Howard, because it's something that requires so little technology, but is a huge change, management effort and cultural shift. Another example I would...
Usually we talk about change management for the patients. This is for the physicians. Yeah. You tell a doctor that they're going to see all of your notes, and it's a very interesting discussion.
Another example I would give, I just came this afternoon actually from a meeting about our inpatient edutainment system. So you check into the hospital and you get to select the movies that you want to see, just like a hotel. And yet we're now starting to think of that not as a engineering technology for patient satisfaction, but as a clinical application. So we have evidence from another children's hospital that put the photographs of their care team members on that television. So by the time a family was checked in and in the patient's room, turned on the television, the care team members populate, and they found that identification of their care team went from less than 20% to over 80% with that simple change. And that has direct correlation to not just patient satisfaction, but patient safety and other significant clinical outcomes. So there's a lot of opportunity, I think, as Howard said, that we're very early in this.
Rajiv, any last words?
No.
So I think from an infotainment, I think it was an entertainment also. So I do want to, congratulate the panel to, participate in this. And if you could be kind enough to give them a big hand. Thank you very much. Thank you. Nice job. Thank you. Let's do a selfie. Come on, Howard.
Selfie.
You and your selfies.
Howard, you're on the edge over there.
Good, he missed.
Wide angle.
No, hang on. It becomes correct.
Okay, while they're doing that, I just want to say that I think I speak hopefully for the room to say that we feel very fortunate to have this panel sitting behind me right here. They're incredibly competent in taking these messy, complicated situations, these inner workings of healthcare systems, which we all know are very, very, very messy, and honestly articulate them very gracefully. And so for that, I just want to also say thank you.